This meeting is for parents and physicians, and we really make no apologies for the level of erudition that's involved in these talks that are given. They're pitched to the physician, but we've been reassured multiple times through the years by parents that they really don't want to be talked down to. They really would like to have good, hard, scientific stuff, and even though there's stuff that they may not understand, nonetheless, it's good to have been exposed to it. Second, with respect to the physicians, I would emphasize in the strongest possible terms to you that you really will be well served to pay attention to the website, uvitis.org. Everything that you're hearing, plus 1,000 times more, is there on that website. Second, everything that's there is yours for the taking. It's all free. There's nothing commercial about it. You're free to download anything there, including Dr. Anisi's comment about the Review of Systems questionnaire. Feel free to search on that, find the ROS, download it, copy it, have it in your offices to give to new patients to fill out before you see them. Now, having said those things, I'll move along to make sure that parents in particular know a little bit about the special challenges that your child's eye doctor faces when your precious child climbs up into the chair. I also will mention to you that all manner of stuff that I'm going to talk about today is off-label in terms of medication use, not FDA approved, but nonetheless represents, in my view, standard of care. I don't have any financial relationships at all with any drug companies regarding anything that I'm going to speak about today. So the learning objectives of this talk include remarks about the child having symptoms or not having symptoms and the special challenge that that poses, the challenges of actually testing the child in terms of visual acuity and pressure, the examination techniques that can be employed to get around some of these challenges, and the most important impediment, the matter of inflammation that persists in spite of everyone's best efforts. Now, the child's symptoms really can depend on the child's age, and the younger the kid, the fewer the symptoms, the less likely the child's actually going to call the parents' attention to the fact that there's a problem. And because of that, the active inflammation may exist for very long periods of time before somebody realizes that, in fact, there is a problem. And finally, where is the inflammation? If it's up front, then it may become more apparent earlier than if it is deep back in the back of the eye. Typically, classically, anyone with uveitis ought to have the top 3 items on this bulleted list. The eye ought to be red, the patient ought to complain of pain, and there ought to be light sensitivity. And yet, classically, for reasons that are completely obscure, the child, especially with JI-associated uveitis, will have none of that. This was the case with my wife when she was 7, 8, 9, 10 years old. Floaters, if they have peritonitis, the child will commonly call that to the patient's attention. They may have ptosis or a droopy upper lid. That could be the first signal that there's something not right. Or they could have a so-called squint, or an eye that drifts in or out. Or the parent may notice something a little white on the front of the eye. Here's a typical example of an adult with acute anterior uveitis with so-called ciliary flush or engorgement of blood vessels at the corneoscleral limbus. The child will almost never have this, and so we've lost that as an early sign that the kid has active uveitis. Precipitates on the cornea. Keratic precipitates on the back of the cornea, these collections of white blood cells. And they're not at all obvious to the parent, but this is one of the things that the ophthalmologist will see and will tell the ophthalmologist that this patient has one type of uveitis or another and lead him or her down a particular path in sorting out the underlying cause of the uveitis. Band keratopathy is a collection of calcium that develops in the cornea, just under the epithelium. And it's curious. I don't understand this one either. Maybe Dr. Sin from NIH can enlighten us all later about why it is that adult onset uveitis almost never, ever is associated with this. If one sees calcium in the cornea in a 25-year-old, you can almost be guaranteed that that person's uveitis began when that person was a child. There's something different about the adult cornea and the child cornea. What about vision testing? The kid may be preverbal. There are ways to test with toys or lights. Can they fixate on the object that the doctor's holding up in front of them? Can they follow it when it's moved? One eye's covered, and lo and behold, they follow well. The other eye's covered. My goodness, the child doesn't follow the toy anymore. Visual acuity testing, typically with figures or the so-called tumbling E, misspelled here, and of course regular letters. Very important for the parent to work with their child. If in fact they're quite young, they can't do these things yet, they can't even cooperate adequately for a slit lamp examination. I try to encourage my parents to develop a game with the child at home and play that game a couple times a week. And that game involves playing eye doctor. The kid gets to do it, the parent gets to do it. And it's played with the kid resting their chin on a table, coffee table, kitchen table, whatever, and the parent then has a light. It can be a flashlight. And they're examining the eye, and then they take turns doing that. And by doing that, the child can develop some familiarity with the process of sitting, being still, resting with their chin on something while a light is shined into the eye. Pressure testing. I tested a child's pressure this morning in the office here at Mercy at 7:30, and I did it by tactile tension. That is to say, I didn't use an instrument. Instruments are better, but even if one can't do it because of lack of cooperation, the doctor, if the doctor has made a specific effort through the years by using two fingers and palpating through the lids, not only on himself but also on multiple patients, and then turning around and testing the pressure with the tonometer. Estimate, commit to the number, test, and how close were you. By doing that, over the years, a doctor can get incredibly good at estimating the pressure inside the eye. Pneumotonometry is generally well tolerated. We have this at Mercy. It doesn't involve the detail precision that the patient has to remain so quiet with the eyelids so wide open while the blue light applanation tonometer is used and does give a very accurate reading. The same is true for the tonopen that can be done in the waiting room as opposed to in the examining chair. Ocular response analyzer, I don't have one of these yet. I'm lusting for one. They're very expensive. I don't know whether or not the Mercy Chief Operating Officer will allow me to buy one for Christmas, but this is an example of that. It can be very, very good for getting pressure measurements in a child. Anterior chamber reaction. Two things. Number one is cells. You can see those individual specks or inflammatory cells. These are white blood cells in the anterior chamber in this excellent photograph. And it's graded like almost everything in medicine on a scale of 0 to 4+, 4+ being too numerous to count. The grading systems are seen in our textbook on uveitis and by the SUN, the S-U-N publications as well. The more cells, the more violent the inflammation, and the more aggressive the medication is going to have to be. Estimating flare is a little trickier. It can become chronic if the patient's had long-term uveitis and it's taken a long time to get it under control. It does represent protein leak from damaged vasculature, and we used to eschew it as a trigger for increasing vigor of therapy. That thinking's changing a little bit now with the advent of so-called flare meters that can be used to accurately measure the Tyndall effect inside the anterior chamber. Here is one of them. We do have this at Mercy. And Gary Holland in California and Janet Davis in Miami, I think, have shown fairly conclusively that flare counts. Flare does matter, and if one can see a reduction in flare, no cells there, plenty of flare, more increased therapy, flare goes down, probably that matters, and probably one ought to use the diminished flare as a target for pressure. Vitreous haze, looking at the haziness or cellular activity or what have you back in the vitreous gel is incredibly frustrating. All ophthalmologists hate this. There's no good way to do it. We use a standardized series of pictures, as you see here, to go by the degree of haziness. Well, you can see the optic nerve quite well here. There's no haze in the vitreous, whereas you can't even see it here. A lot of haze in the vitreous there. But this is really subjective and imperfect, and we all wish we had a better way to do this. You can see that the chief down at NIH, Bob Nussenblatt, developed this series of photographs back in 1985. And here we are 25 or more years later, still using that, don't tell Bob I said so, retarded system for yeah, oh yeah, yeah, Bob is clearly not retarded.
No, I'm sure he wishes they had a better system too.
Yeah. So stubborn inflammation, that other thing that we spoke about in regard to challenges, special challenges, is just a horrible problem. You're going to see later on in one of my talks, you'll become sick of probably the same message, namely delayed referral, chronic inflammation is the #1 problem that's causing blindness in our children today, our children who have uveitis, and still yet today in 2012. So, a slit lamp examination by an experienced specialist is frequently necessary to establish the diagnosis and make judgments about how significant a problem is it. Vision and intraocular pressure measurements are important and yet imperfect in terms of precision today in most children. Patience, rewards, preparation may ease examination anxiety. That's directed to all the parents in this room. If you have a child, most of you don't, because most of you have children who've been on this path for quite a while, but if you know of a child who's struggling with respect to their eye doctor visits, remember these things: being patient, offering rewards before and after the eye doctor visit, and preparing with the kinds of exercises that I alluded to earlier may ease the process. Childhood uveitis is frequently a very long-term matter, requiring multiple visits to the doctor and visits to multiple types of doctors. It's a pity, it's a real pity, when a family gets dealt this hand. It's a tough hand. And some people give up. Some people don't have what it takes. We've got people here from Canada and Louisiana and God knows where else. Clearly you have what it takes to engage and stay in the hunt. But it's a long game. If one does engage and stays in it over the long pull, this is a game that can be won. This disease is curable. This is curable, not controllable. None of this matter of long-term therapy for life. This disease is curable.